Okay, let's unpack this. When most of us hear the word diabetes, we instinctively think of type 1 or type 2.
Right. Pretty much, yeah. Those are definitely the headliners.
And while those are certainly the most common, accounting for a vast majority of cases, what if I told you that our understanding of diabetes is far broader? That it encompasses a complex spectrum of atypical forms that don't fit neatly into those two familiar categories.
What's truly groundbreaking, I think, in this area is how our scientific understanding of diabetes is continuously evolving. It's really moving fast.
Yeah.
Yeah. The traditional classification, though, foundational, it's constantly being refined. We're accounting for an increasing complexity in causes and disease progression.
So not so simple?
Not at all. Our deep dive today aims to illuminate this broader landscape for you, revealing distinctions that could fundamentally change how you view this common condition.
Absolutely. We've distilled a stack of the latest research and clinical insights into this conversation, giving you a shortcut to being truly well-informed. Get ready to explore the hidden nuances and fascinating distinctions in the world of diabetes. So, to set the stage, while type 1 and type 2 diabetes cover most cases, there's a significant portion, we're talking maybe 5 to 10% of all diabetes diagnoses that fall into what we call atypical forms. What generally makes them atypical, and why is it so important, really, to understand this distinction?
That's a crucial question. These atypical forms are driven by very specific underlying causes or unique pathways that go beyond the usual suspects of type 1 and 2.
Okay.
And, the genetic basis of even classic type 1 and type 2 are remarkably complex. Lots of common genetic variants, each conferring only a small degree of risk individually.
Right, it's not just one gene flips a switch.
Not usually, no.
Oh.
Then you factor in the global rise of obesity, especially concerning type 2 diabetes, and the picture gets even more intricate.
Yeah, that complicates things.
It really does. So the goal, therefore, is to continuously review our current classification so we can include these emerging atypical forms. This leads to a much more precise understanding for, well, both diagnosis and treatment.
Makes sense. Let's start with type 1 diabetes, then. Most of us probably envision the classic picture. The immune system mistakenly attacks and destroys the insulin-producing beta cells in the pancreas,
Right.
leading to an absolute lack of insulin.
That's the hallmark. This autoimmune process leaves telltale footprints, specifically autoantibodies that we can test for.
Autoantibodies, okay.
Now, the names can be a bit of a mouthful, like GAD65, glutamic acid decarboxylase 65, or ZNT8, zinc transporter 8.
Yeah, definitely a mouthful.
Yeah, but the key takeaway is that these unique markers are what pinpoint the immune attack, even when diabetes appears in maybe an unexpected way.
Got it.
It's also worth noting there's a form called idiopathic, or sometimes type 1b diabetes. Here, the beta cell destruction happens, but the underlying cause isn't autoimmune. The trigger is unknown.
Interesting. Okay, here's where it gets really interesting, I think, especially for adults. Latent autoimmune diabetes in adults, or LADA.
Ah, yes, LAD.
It sounds complex, but it seems like a crucial piece of the puzzle. What exactly is LADA, and why does it sometimes get missed?
So LADA is essentially type 1 diabetes that emerges in adults. But unlike the, often rapid onset seen in childhood type 1,
Right.
LADA is characterized by an adult onset. You still have those positive autoantibodies, but there's a slower, more gradual progression of insulin deficiency.
Lower.
Yeah. So patients with LAD might not actually require insulin treatment right at diagnosis.
Ah, so they might look like type 2 initially.
Exactly. That's the key confusion point. They look similar to type 2, but they almost always eventually will need insulin. It's also quite heterogeneous, meaning it varies a lot.
How so?
Well, you see varying levels of autoantibodies, different body mass index or BMI, and diverse rates of progression towards needing insulin. All that variation is why it can be challenging to diagnose initially.
This distinction for LADA is incredibly important because for you, the listener, it means that even if you're an adult diagnosed with what seems like type 2, there might be this deeper autoimmune component that really needs a different approach. Precisely. LADA often differentiates from type 2 by, say, an earlier age of onset than typical type 2, generally a lower BMI, and often a personal or family history of other autoimmune diseases.
That family history is a big clue sometimes.
Right, and getting that diagnosis right is absolutely critical for effective management down the line.
Absolutely. And beyond LADA, there are even other unclassified autoimmune forms of diabetes.
Oh.
Yeah, these are individuals who have those type 1 associated autoantibodies, but don't fit neatly neatly into either type 1 or type 2 boxes.
Mm-hmm.
Or sometimes we see type 2 patients who present with humoral biomarkers of T-cell mediated autoimmunity, basically, immune system footprints.
Footprints, okay.
Suggesting a broader spectrum of immune involvement than we previously understood. It's a complex picture.
So we've peeled back the layers on type 1, but what about its far more common cousin, type 2 diabetes? Many of us think we know that story: insulin resistance, obesity, but it sounds like it's just as complex.
It really is.
Right.
While type 2 is the most common phenotype, characterized by that insulin resistance and variable degrees of impaired insulin secretion, often strongly linked to obesity.
Mm-hmm.
It's far more diverse than many realize. Researchers using machine learning approaches have actually identified distinct subtypes within type 2 diabetes.
Machine learning. Wow. What kind of subtypes are we talking about?
Well, they've proposed categories like severe autoimmune diabetes, or SAID, which sounds a bit like LADA, actually.
Right.
Then there's severe insulin deficient diabetes, SIDD, severe insulin resistant diabetes, SIRID, mild obesity-related diabetes, MOD, and mild age-related diabetes, ARND.
That's quite a few specific types branching off from just type 2.
It is. And what's particularly important here is that these subtypes can even be linked to specific genetic variants.
Ah, genetics again.
Exactly. And this isn't just academic, It opens the door to truly personalized treatments, potentially revolutionizing how we manage type 2 diabetes by targeting specific pathways, not just general symptoms.
That's a surprising revelation that type 2 isn't a monolith. Now, what about diabetic ketoacidosis, or DKA? We typically associate that severe complication with type 1.
That's the common association.
But you're saying it can happen in type 2 as well. How does that work?
It's a great question. While DKA is a hallmark of severe insulin deficiency in type 1, it absolutely can occur in type 2. It's often triggered during periods of severe physiological stress. Think a major heart attack, trauma, or a serious infection.
So the body is under extreme pressure.
Right. It can also be the initial presentation in patients with something called ketosis-prone diabetes mellitus. This is a specific subtype of type 2 where individuals might appear to have typical type 2 but can quickly develop DKA when stressed. The underlying mechanism is still a severe lack of effective insulin action, but it's often triggered by these significant external factors in type 2 rather than the baseline absolute deficiency of type 1.
Got it. So with all these variations and overlaps, type 1, type 2, LADA, these new type 2 subtypes, how do doctors actually distinguish between them, especially when they can present so similarly? What should you, our listener, know about how this is untangled?
Yeah, it can be tricky. It really comes down to a combination of clinical features and, importantly, targeted testing.
Okay, like what features?
Well, age of diagnosis can be a clue. Type 1 often presents before age 25, but honestly, it can be any age. Type 2 is typically diagnosed later, though. Worryingly, we're seeing it more in adolescence now.
Yeah.
Monogenic diabetes frequently shows up before 25.
And weight.
Weight can also be a hint. Type 1 patients are usually, though not always, thin, whereas over 90% of type 2 patients are overweight or obese. Monogenic forms are more variable, often similar to the general population.
And the autoantibodies we talked about.
Crucial. Present in type 1, typically absent in type 2 and monogenic forms. Insulin dependence is another key factor, usually required in type 1 from the start, initially not in type 2, and in monogenic forms, it really varies.
What about family history?
That's often quite telling. It's often infrequent in type 1, maybe 5–10%, very common in type 2, like 75–90%. And often strikingly multi-generational in monogenic diabetes, you might see it across 3 or more generations.
Wow, 3 generations.
Yeah. Finally, the risk of DKA, high in type 1, generally low in typical type 2, and also generally low in monogenic forms, unless there's a specific stressor like we discussed.
Okay, that helps clarify the landscape.
Yeah.
Given all these nuances, though, when should that autoantibody testing actually be considered, especially if someone doesn't quite fit the classic type 1 mold?
Right, it's not needed for everyone diagnosed. But islet autoantibody testing is incredibly useful in several specific situations where there's an overlap in presentation between type 1 and type 2. You definitely consider it in atypical type 2 presentations. Or if someone just isn't responding well to initial type 2 therapy, like, say, sulfonylureas or metformin.
Okay, that makes sense.
It's also really important for adults diagnosed with diabetes who don't have overweight or obesity, or those with a personal or family history of other autoimmune diseases.
The autoimmune connection again.
Exactly, and definitely in children and young adults, say under 30 years old.
Yeah.
Also, if there's unintentional weight loss or ketoacidosis at the time of diagnosis, testing is highly recommended.
And how many tests do they usually run?
Good question. To increase the chances of catching it, it's best practice to measure at least two types of islet autoantibodies, like ICA, GAD65, IA2, or ZNT8. One might be negative, but another positive.
Got it. So testing strategically, that's a crucial point about autoantibodies, hinting at the deeper biological drivers. And speaking of deeper drivers, it sounds like genetics isn't just about general predisposition, but something far more specific sometimes.
Oh, absolutely.
This brings us to a truly fascinating area, monogenic diabetes.
Indeed. Monogenic diabetes, which used to be known mainly as maturity-onset diabetes of the young, or MODY.
MODY, right? I've heard that term.
Yeah, it's a unique form that results from a defect in a single gene, just one gene causing the issue.
One gene. That's specific.
Very specific. And it's typically inherited in an autosomal dominant pattern,
Meaning?
meaning it often runs very strongly in families. If a parent has it, each child has a 50% chance of inheriting it. While it accounts for a small fraction of total diabetes cases, maybe 1–2%, it's frequently misclassified as type 1 or type 2.
And that misclassification matters.
Hugely. It can lead to incorrect or significantly delayed treatment, which can impact long-term health.
What's truly captivating here is how these different single-gene mutations lead to specific forms of monogenic diabetes, each with its own unique clinical features. Can you give us some examples of how these genetic differences actually manifest?
Certainly. So one less common type involves a gene called HNF4A, that's MODY1. This primarily causes reduced insulin secretion, but interestingly, it often responds remarkably well to certain oral medications called sulfonylureas.
So maybe no insulin needed, even though it affects insulin secretion?
Potentially yes, at least for a time. Then there's a mutation in the glucokinase gene, GCK, which causes MODY2. This one is fairly common among the monogenic types.
What does GCK Melody Y look like?
It leads to mild, stable fasting hyperglycemia, slightly high blood sugar when fasting, but it doesn't tend to get much worse over time. It's often discovered incidentally during routine tests.
So people might not even know they have it.
Often, yes. And it usually doesn't require medication because it's generally a milder, non-progressive form. One interesting wrinkle, it could also cause gestational diabetes if the fetus inherits the gene from a parent during pregnancy.
Huh. Okay, what else?
Well, the most common type by far, making up maybe over half of all monogenic cases, involves the HNF1A gene. That's MODY3.
MODY3, the most common.
Right. This causes abnormal insulin secretion and something called a low renal threshold for glucose.
Low renal threshold, what's that?
Basically, it means glucose spills into the urine at lower blood sugar levels than usual. Think of your kidneys as having a filter for sugar in MODY3. That filter is a bit leaky.
So sugar in the urine doesn't automatically mean very high blood sugar in this case.
Correct. MODY3 also tends to respond well to sulfonylureas and sometimes metformin, but we do know that patients with this type may have an increased cardiovascular risk, so that needs monitoring.
Fascinating. Are there others?
There are rarer types too, like those involving IPF1 or HNF1B. HNF1B or MODY5 is notably associated with pancreatic and kidney issues, like cysts, and neurogenic differentiation, factor 1, MODY6. The list keeps growing as we learn more.
So with these really specific forms, what does this all mean for you, the listener? If monogenic diabetes is suspected in your family, or maybe for yourself, what steps should be taken?
Right, so the indications for genetic testing are quite specific. You don't just test everyone. It's recommended if diabetes is diagnosed relatively young, say before age 25, especially if the person doesn't fit the typical type 1 or 2 picture. Maybe they have a low BMI.
Okay.
A really strong family history is a major flag, especially seeing diabetes across 3 or more generations.
Really generations, yeah.
It's also incredibly useful in people presumed to have type 1 who test negative for all the autoantibodies, but still show signs of making some of their own insulin, measured by something called C-peptide.
Ah, so the puzzle pieces don't quite fit type 1.
Exactly. In these cases, genetic testing is the definitive diagnostic method. And genetic counseling is really important alongside it.
Why counseling specifically?
Because getting the right diagnosis can fundamentally change treatment. Like we said, some individuals with certain monogenic types can potentially switch from insulin injections to taking oral medications, like sulfonylureas. That's a life-altering difference.
Absolutely huge difference. Okay, so beyond the major types, type 1, type 2, and these fascinating monogenic forms, our sources highlight even more specific and sometimes, frankly, unexpected causes of diabetes. What are some of these less common drivers we should just be aware of?
Yeah, there's quite a range of other specific types that don't fit the main categories. For example, diseases of the exocrine pancreas.
The part that makes digestive enzymes.
Exactly. Things like chronic pancreatitis, cystic fibrosis, trauma to the pancreas, or even surgical removal of pancreatic tissue can directly impair insulin production, often leading to diabetes that needs insulin.
Makes sense if the organ is damaged.
Right. Then there are endocrinopathies. These are hormonal imbalances caused by other conditions. Think Cushing syndrome, which involves excess cortisol, or acromegaly with excess growth hormone, or pheochromocytoma. These can drastically impair glucose regulation.
So other hormones interfering with insulin.
Precisely. We also see drug-induced diabetes. Certain medications, like glucocorticoids, some antipsychotics, or drugs used after organ transplants, can affect glucose tolerance or cause insulin resistance.
Something to be aware of if starting new meds.
Definitely worth discussing with your doctor.
Yeah.
Viral infections have also been implicated. Viruses such as Coxsackie-B, mumps, rubella, and notably even SARS-CoV-2, the virus behind COVID-19, have been linked to new-onset diabetes or making existing diabetes worse.
The COVID link is worrying.
It's an area of active research. And of course, there's gestational diabetes mellitus, GDM, which develops during pregnancy, typically in the second or third trimester. It happens when the body just can't produce enough extra insulin to meet the increased demands of pregnancy.
Right.
Finally, there are very uncommon immune-mediated forms, like stiff person syndrome, which has associated autoantibodies, or extremely rare genetic defects in insulin action, not production, like Wolfram syndrome, which tragically combines diabetes with other neurological and sensory issues.
Wow. It really underscores that diabetes isn't just one thing. It's clear that it's far more complex and varied than many of us realize. It truly is a spectrum of conditions, not just two types.
That's exactly right.
It's almost like discovering there are dozens of shades of blue when you only thought there were two. And it's such a powerful reminder that getting that accurate diagnosis can lead to truly personalized and much more effective treatment.
That's the core of it, really. While type 1 is fundamentally about absolute insulin deficiency from beta cell destruction, and type 2 primarily involves insulin resistance with variable insulin secretion. Recognizing these atypical forms like LEDA and the monogenic types is absolutely critical for appropriate management. Understanding these nuances allows for a much more precise, tailored approach to care. It helps ensure individuals get the right treatment for their specific type of diabetes, leading to far better outcomes in the long run.
So what does this all mean for you, the listener? If you or someone you know has diabetes that doesn't quite fit the typical picture, maybe the age of onset was unusual, maybe weight isn't a factor, maybe treatments aren't working as expected, this deep dive shows there's a compelling reason to ask deeper questions and explore further possibilities with your healthcare provider.
Absolutely. And this raises perhaps an important question for you to mull over. How might a more precise understanding of chronic conditions like diabetes, moving beyond these broad categories towards individual genetic and physiological profiles, fundamentally change the future of healthcare and usher in an era of truly personalized medicine?
A fascinating thought to end on. Thank you for joining us on this deep dive into the complex world of diabetes classification. We hope you feel more informed and definitely more curious about the incredible complexity of the human body.